Can you count the, okay, like atrial rate and ventricular rate? Ventricular, oh no. Progressive prolongation of it may be a movie start. This is progressive prolongation, then a drop bit, isn't it? Drop is both for type 1 and 2. But for type 2, PR is equal. Like PR is constant. Got my point? Like the drop bit will not gonna follow this pattern, like progressive prolongation of the PR interval, then a bit is dropped. Yes, yes. So progressive prolongation of the PR interval, then a drop bit, that is type 1. Okay, I am sharing my screen. You can share your confusion. That would be helpful. Okay, you are talking about the V5, isn't it? So this P is not visible. So look from start from this P. So onset of P wave and onset of QRS complex. So this P wave and again this P wave has biphasic. It has two phase. There are plenty of P wave like biphasic inverted P wave. So it looks like biphasic P wave. So this P wave starts with here to here, here. So this PR interval. So this one is larger from this. This one is again larger from this. This one is far larger from this, and then a drop bit P wave not followed by QRS complex. Got it? And like Mobis type 2, uh, there is PR interval is constant. Okay, look in here, PR interval is constant. PR interval is constant, but there is a drop bit. Here you get the drop bit, but the PR interval is constant. Got it? No, end, not end. The starting. No, they put this one is the okay. The you are talking about this point, isn't it? But the keyword s is of ends at here, and there is narrow QRS complex and the complete heart block. Look at the complete heart block. In complete heart block, I have always told you atrial rate and ventricular rate, like regular PP, regular RR. Look at the PP, look at the PP, and look at the RR, and ventricular rate is less than 50. If you calculate from here to here, this rate is below 50. And QRS complex is white. QRS complex is white. This is the QRS complex which is widened QRS complex. But Mobis type 2 has narrow QRS complex. Got it? And first degree is just the PR prolong. Yes, whenever there is a drop, so no first degree. Okay, you can share your screen. Hard block is always problematic, I know. Yes, next. Is it coarctation, hypertension, saturation is higher in the right hand than the left foot? You got wrong. You have given in the form of coarctation. Okay, this is persistent pulmonary hypertension of the newborn. What you have said in the coarctation to according to the picture, can you describe it again? Yes, yes. It, it's equal. Yes. So, if preductal and postductal oxygen saturation is different, then we will think about the persistent pulmonary hypertension of the newborn. Okay, look at the okay, I am explaining the most important thing, like the examination finding in the before treatment in the box, decreased postductal relative to preductal oxygen saturation. So postductal is 91 and preductal is 99 oxygen saturation. So if there is saturation difference, so think about persistent pulmonary hypertension of the newborn. Apart from it, is there anything we can find for remembering this? Yes, I can read the explanation. Just try to find the clue. What have you seen in this question? I'm reading the explanation. You try to find the find something important. Okay. This patient's low preductal, like right foot saturation relative to her preductal. So this patient's low postductal right foot saturation relative to her preductal right hand saturation is consistent with right to left shunt across the PDA. Because this patient has a strong distal pulse, the most likely diagnosis is persistent pulmonary hypertension of the newborn. At birth, physiologically elevated pulmonary vascular resistance, physiologically elevated pulmonary vascular resistance, PVR, normally decreased with oxygen and ventilation of the lungs. In persistent pulmonary hypertension of the newborn, also known as persistent fetal circulation, the PVR remains elevated. PVR remains elevated. Deoxygenated blue blood, deoxygenated blood crosses the pulmonary artery into the aorta, mixes with oxygenated red blood pumped from the left ventricle, resulting in relatively lower postductal saturation. Risk factors for persistent pulmonary hypertension include condition associated with lung hypoplasia, congenital diaphragmatic hernia, Potter sequence infection, pneumonia, meconium aspiration. However, some patients have identifiable cause and simply have a slower decline in the uh, pulmonary vascular resistance, resulting in mild right to left shunt that can persist into the first few days of life, as is likely in this neonate. Respiratory distress and cyanosis are common, but some patients are asymptomatic. Okay, normal. If this pulse abnormality like higher brachial, lower femoral, then we will think about the coarctation. Yes, right to left shunting across right to left shunting across the ductus arteriosus also occurs in conditions in which left ventricular output is obstructed, such as coarctation of the aorta. However, these infants have diminished femoral pulses and often lower extremity pallor due to decreased distal flow. This patient has normal femoral pulses, making hypoplasia of the aortic arch unlikely. And the choice B, left to right intracardiac shunts, atrial septal defect, ventricular septal defect, causes oxygenated blood to return to the right sided circulation before being pumped to lungs again. Unlike these, unlike in this patient, pre and postductal saturation would be equal and normal. So in ASD and VSD, pre and postductal saturation would be normal. Okay. Yes. Wait. Just hear the murmur. Try to. Wait. I am telling you the way of hearing. Like whatever you heard the sound, there is no, like try to remember one sound. In this sound there is no abnormality, it is continuous in manner from start to end. There is no sound abnormality. Listen to this, it's all the same. So it is continuous in manner, so it's PDA. No, again again you heard again. And I try to and now I will make you learn. Like look at the you heard the ASD. Yes, you are trying to give the ASD one. Okay, listen to this murmur. You play. Can can you get the difference? So this sound is not continuous like the ASD. There is something difference. Like if you use flute, or if you use something, any musical instrument, if the musical instrument is continuous in pattern, that is PDA. So one you can diagnose. Got it? Okay. Okay. We will discuss later. Next, because the murmur, if we are trying to hear and we are trying to, it will be very hard. So we will do it one by one. Like we try to remember one to two murmur at we will try to remember one to two murmur, and then we'll try to again we'll try to do another two murmur. If we do in that way, we can remember all the murmurs. Got it? Okay, so you will never gonna forget the PDA one, isn't it? Hopefully. So the important murmur, like I have found the near about 5 to 6 murmur, like ASAR, S3, S4, and the PDA one. These five murmur is very important. AS is very common. AS murmur is very common. And AS murmur, if the scenario is given, AS murmur is very like 70-year-old man. Hopefully it is AS. And S3, S4 is very hard actually. That's why these two murmur you have to hear plenty of time. And the PDA is very easy. It is continuous in pattern. If you hear the murmur while you are solving the question, you will get the difference. Like now you get the difference. You if you uh, if you hear all the murmurs, you can get you will get the idea of the PDA. Got it? Okay. Okay. This patient with sharp pain that begin 2 to 4 days, that begin 2 to 4 days. Sorry, this patient with sharp pain that begin within 2 to 4 days following myocardial infarction likely has peri-infarction pericarditis. Peri-infarction pericarditis results from localized inflammation triggered by transmural myocardial necrosis following ST elevation MI, and is best prevented by early PCI, early coronary reperfusion therapy, which helps minimize myocardial necrosis. Treatment is usually supportive, but high dose aspirin is sometimes given to alleviate severe inflammation and pain. Corticosteroid as non-steroidal inflammatory drugs other than aspirin, ibuprofen are avoided due to impairment of collagen deposition and a potential increase a risk of free wall rupture. potential increased risk of free wall rupture. Post-cardiac post-cardiac injury pericarditis Dressler syndrome is differentiated from PIP, peri-infarction pericarditis, in that it results from the production of antibody to myocardial antigen and occurs a week to several months following MI. In addition, post-cardiac injury pericarditis typically involves diffuse rather than localized pericardial involvement. So, post-cardiac injury pericarditis, Dressler syndrome, is differentiated from peri-infarction pericarditis. It results from the production of antibody against myocardial antigen occurs 1 week months following MI. I'm not getting it. What this line? So if it happens within 2 to 4 days, it is peri-infarction pericarditis. If it happens after weeks to months, then it is Dressler syndrome. Okay. Maybe high dose aspirin. Yes, peri-infarction pericarditis. There it is written in high dose aspirin, and post-infarction pericarditis Dressler. There is 975 milligram of aspirin. Yes, yes. We have read one of the question. Okay. Yes. Mm, I don't think so. Looks like the patient is re-evaluated in 20 minutes after arrival. Reports persistent chest pain. What is the most? Okay. ECG may be normal. Wait. Why you are sending the patient to cardiac catheterization unit? You haven't diagnosed the ST elevated MI. This is normal. So you think a patient comes to you, ECG is normal, but you feel that the pain looks like cardiac pain. So what you will do? Initially, in if the patient comes early, ECG may be normal, and then yes, that's the thing. Like in cardiology, think the patient is in front of you, then you will then it will be easier for you to think. Okay, I know I am explaining a lot. Okay, okay. The question stem is very atypical. That's why I am explaining a lot. Okay, so this patient risk factor like age, male sex, hypertension, and a clinical presentation more than 30 minutes of the substernal chest pain concerning for acute coronary syndrome in patient with suspected ACS who go on to have acute MI. The initial ECG, ideally obtained within 10 minutes of the emergency department arrival, is often normal, as in this case, or non-diagnostic, regardless of cardiac biomarker level. Changes ST segment elevation or depression on subsequent ECG can develop quickly or may significantly affect patient management. In particular, ST segment elevation warrants emergency cardiac catheterization with PCI. A delayed or misdiagnosis can worsen the patient outcome. Therefore, high-risk individual, those with ongoing symptoms such as these patients, serial ECG should be performed. Serial ECG should be performed in the emergency department at frequent interval 15 to 30 minutes along with serial measurement of the cardiac biomarkers. If serial ECG and cardiac biomarkers are normal, suspicion for ACS remains. Bedside echocardiography can be considered to look for wall motion abnormality. Got it? Yes. Patients with presentation concerning for ACS are often admitted to patient with presentation concerning for ACS are often admitted to telemetry like cardiac monitoring unit and evaluated with serial biomarker measurement. However, serial ECG should be obtained in the emergency department uh, prior to disposition, particularly in the presence of persistent chest pain, because abnormality may warrant different intervention, PCI, anticoagulation. Patients with ST segment elevation meeting certain criteria have improved outcome with emergency PCI and should be sent to cardiac catheterization unit. This patient's initial ECG does not demonstrate ST segment elevation and does not meet the criteria for emergency PCI. Got it? Like negative finding means ECG ST is not elevated and troponin is negative. Serial ECG and troponin, if positive, then admit for further management. Se- Serial ECG and troponin, like negative finding, like ECG is normal, like in this patient ECG is normal, and if in this patient we do troponin, troponin will be normal too. Got it? And no, so if the negative finding, you will do serial ECG and troponin, like you will not just send the patient, you will wait patient, you will make the patient wait in the emergency room for doing ECG again. Like you will tell the patient we will do ECG 10 minutes, 20 minutes later, and you will do again another ECG. If that ECG and troponin is again negative, then non-invasive test should be done. Yes, yes, yes. Yes. Or there are some issues like if there is unstable angina or Prince-Metal angina, sometimes there is only troponin is elevated, but there is no ECG changes. If troponin is elevated, that means cardiac muscle has some sort of injury. That's why the troponin has elevated, isn't it? So we need to wait. We need to admit the patient, as we know that ECG will gonna elevate very soon. High two. Yes. Isn't it hypotension, tachycardia, tachypnea? ECG shows either it is pulmonary embolism, ECG shows sinus, or it is cardiac tamponade. It is, I think that it's in between these two. Yes, he has. He was seen in the office progressive exertional angina and shortness of breath 2 weeks ago, though. Okay, that's why see coronary angiography done. Yes, all the pressure will increase. I think the echo should be done. It's temp. Yes, on both cases. Like if you think in both cases, echo is the answer. Why I have said, if you think pulmonary embolism and the patient is hemodynamic unstable, what will you do? Echo. And if you think it is cardiac tamponade like hypotension, tachycardia, tachypnea, the again echo is the answer. And in cardiac tamponade, like in cardiogenic shock, you will get right sided preload will be high, and pulmonary capillary wedge pressure is also high. Uh, can you do you remember that particular line on that thing that measured PCWP is higher, but actual WPC is lower. So that is happened in here. Like if you find just find the shock, find the shock um, box. Can you find the shock box, like where cardiogenic shock, pulmonary, all the shocks are present? No, no, you didn't need to exit. You can go again. You can log in with another USML, your own ID. Yes, you can. Look, I have opened. Okay, you don't know that. I don't know why you don't know that. Look at my screen. Can you see my screen? Okay. One, I am doing question. This is my, I am using one ID, but I have logged in twice. Got it? Yes. So what I do in that way, like when I try to find a question, like I have told you, I try to find the shock question. So I search the shock and I do this block too. Got it? So you can find the shock. No, in here shock. Like you can type whatever you want, like shock. Okay. Oh no, no, search. This search button, this search button, this is the search button, and you can find, like I am finding the shock actual. uh, there are plenty of shock questions, so yes, that this would be easier. I okay. Yes. Okay. uh, okay, where? Okay, where? We will find the box very soon, no problem. I Yes, this one. Okay, so you can search via this way. One, you will do the question. Another tool, you will search the question. Because, and I will tell you one tactic. Like, if you find a topic difficult, like suppose you find the topic difficult, like digoxin toxicity. So you search the digoxin toxicity, and you do all the question of the digoxin toxicity, and and this way you can master on that particular topic. Yes, so I actually follow this rule sometimes. Okay. Okay, I am talking about what? I am talking about this cardiogenic shock. Look, uh, no, sorry, in obstructive shock. In obstructive shock, there is the causes of the obstructive shock is cardiac tamponade. Causes of the obstructive shock is tension pneumothorax, isn't it? Okay, look, pulmonary capillary wedge pressure is down, but in our stem, pulmonary capillary wedge pressure is higher. So why it is higher? So the explanation is given in here. In tamponade, the left-sided preload is decreased, but measured PCWP is paradoxically increased due to external compression by the pericardial fluid. Got it? So that's the explanation. Everything goes, the right sided preload is higher, cardiac index is lower, and systemic vascular resistance is higher. Everything is normal, and normally PCWP is lower, but if it is measured PCWP, it is paradoxically increased due to external compression by the pericardial fluid. That's it. Got it? So you can use these, like you can open another uworld whenever you want to find something. Okay, I'm reading the explanation. Okay, so this patient most likely has a post-operative cardiac tamponade, a relatively rare but important early complication of the coronary artery bypass graft. Rapid accumulation of fluid in the limited pericardial space leads to increased diastolic pressure in the chambers of the heart and severe impairment in venous return. Patients typically have evidence of shock with hypoperfusion, and the classic findings is triad, hypotension, elevated JVP, and distant heart sound. And characteristically, there is an elevation and equalization of the intracardiac diastolic pressure, like atrial, like right atrial, right ventricular, and pulmonary capillary wedge pressure, suggestive of left atrial pressure, as shown on this pulmonary artery catheterization. Cardiac tamponade can rapidly lead to cardiac arrest if left untreated. Urgent echocardiography confirms the diagnosis and can identify moderate or lower pericardial effusion, right atrial diastolic collapse, right ventricular diastolic collapse, highly specific for tamponade, and bowing of interventricular septum into the left ventricle during inspiration. Immediate percutaneous or surgical drainage of the pericardial fluid relieves elevated intrapericardial pressure and leads to rapid improvement in symptoms and hemodynamic status. Got it? Okay. Next. Okay, it's tough. In tough, there are four characteristics anomaly: pulmonary stenosis or atresia, right ventricular hypertrophy, overriding of the aorta, VSD. The relative resistance between the systemic and pulmonary circulation determines blood flow across the large unrestricted VSD. If the resistance of the systemic circulation exceeds the increase if the resistance of the systemic circulation exceeds the resistance of the pulmonary circulation, the blood will shunt from ventricle to the pulmonary artery left to right shunt. However, if the pulmonary vascular resistance exceeds if the pulmonary vascular resistance exceeds the systemic circulation, the blood will shunt from the ventricle into the aorta. The blood will shunt from ventricle to the aorta, right to left shunt, resulting in cyanosis. Okay. Do you want me to read the whole explanation? Okay. Okay, tell me the rate of this patient. Is it over 150 or it is below 150? So if it is 150, so what may be the diagnosis? I told you to remember only one diagnosis. If the ECG show, sorry, yeah, yes, SVT, supraventricular tachycardia, and the drug of choice for SVT, yes. I haven't read the question. I just see the ECG and I know the answer. So this this is actually a clear cut question. Like if somebody got SVT has lots of treatment, but the drug of choice for SVT is adenosine. But the adenosine cannot be given if the patient is asthmatic. So on that case, I think that verapamil is a drug of choice. Okay, it is written somewhere. I don't know. Okay, okay. I am reading the explanation now. Okay, so you understand the ECG, isn't it? In here, look at the P. There is retrograde P wave. Pseudo looks like pseudo R wave. So the P, if you try to find out the P, you will fall in the trap of the P. That's why I haven't talked about the P. Okay. So the ECG shows regular and narrow complex tachycardic urine duration less than 120 at a rate of approximately 160 beats per minute. That's why I'm telling you about the rate. 160 beats per minute. This is consistent with the diagnosis of the SVT. SVT refers to any tachycardia originating above the his bundle, and includes sinus tachycardia. Includes sinus tachycardia, multi-atrial tachycardia, atrial flutter, atrial fibrillation, AVNRT, AB reentrant tachycardia, and junctional tachycardia. Patient usually presents with palpitation, although some may have dizziness, lightheadedness, shortness of breath, diaphoresis, chest pain, pre-syncope or syncope. Paroxysmal supraventricular tachycardia are SVTs with abrupt onset and offset. They include AVNRT, AVRT, atrial tachycardia, junctional tachycardia. In patients who are hemodynamically stable, the next step in evaluation is to identify the type of the SVT with the use of fecal maneuver like carotid sinus massage, Valsalva, eye wall pressure, carotid sinus massage, valsalva, eyeball pressure, or IV adenosine. Adenosine or vagal maneuver temporarily slow down via AV node can aid in the diagnosis by unmasking hidden P wave in patients with atrial flutter or atrial tachycardia. This can cause transient AV node. This can cause transient AV node block and terminate AV node dependent arrhythmia, including AV energy and orthodromic AVRT. Got it? Is early diastolic murmur is AR and PR. Uh, okay. Mitral stenosis typically is mid diastolic murmur. Okay. Early diastolic heart sound. Okay. It may be mitral stenosis. When she is lying on the left side. That means if she is on left lateral position, so murmur may be on the mitral area. It is mitral stenosis, maybe. Pulmonary fibrosis. Oh, okay, you are right, mitral stenosis. So, according to the picture, in mitral stenosis, like central venous pressure is increased. That means right sided preload is increased. Pulmonary capillary wedge pressure, left sided preload is also increased. And as due to mitral valve is narrowing, so cardiac output is decreased. So this patient exertional dyspnea, early diastolic sound, opening snap followed by rumbling diastolic murmur are consistent with mitral stenosis. Mitral stenosis usually occur in the setting of underlying rheumatic disease. underlying rheumatic disease in the United States. It is most frequently present in patients who immigrated from Latin America. Progressive dyspnea on exertion is the common presenting symptom. The hemodynamic alteration that occur with MS result from restricted diastolic filling of the left ventricle. As the severity of the stenosis worsens, there is an increased left atrial pressure that leads to left atrial dilatation and consequent pulmonary artery pressure, systolic and diastolic, then occurs via two mechanisms. The passive component of the pulmonary hypertension is most prominent and results from transmission of the elevated pressure backward from the left atrium to the pulmonary veins and pulmonary capillaries and pulmonary arteries. Clinically, this process is typically evidenced by pulmonary edema as its associated symptoms: orthopnea, paradoxical nocturnal dyspnea, hemoptysis, as well as peripheral edema. The reactive precapillary the reactive or precapillary component of the pulmonary hypertension is only sometimes present, occurs independent of left atrial pressure. In this process, MS triggers endothelin-mediated pulmonary arterial vasoconstriction and pathologic vascular remodeling through the poorly understood mechanism. Left ventricular diastolic pressure is generally unaffected in MS as the left ventricle is downstream of the pathological stenosis. In severe MS, left ventricle diastolic pressure may be lower than normal. Okay, it's post-MI infarction, AC inhibition. If there is myocardial infarct, you give AC inhibitor. It will reduce left ventricular dilatation and more preserve contractile function. Angiotensin II remodeling over weeks to months, infarct ballooning, left ventricular dilatation, and reduce contractile function. Okay, I'm reading the explanation now. So, this patient's myocardial infarction 2 years ago, resulting in left ventricular systolic dysfunction. An autopsy shows a dilated left ventricle with a thin walled and evidence of scarring. These findings are consistent with eccentric hypertrophy due to ischemic heart disease. Both infarction and left ventricular systolic function induce deleterious cardiac remodeling with pathologic pathology, cardiomyocyte hypertrophy, and collagen deposition. These changes commonly progress to cause severe left ventricle systolic dysfunction and create an increased risk of fatal cardiac arrhythmia, which was likely cause of death in this patient. Cardiac remodeling is cardiac remodeling is mostly driven by neurohormonal pathways, including renin-angiotensin aldosterone pathway. Inhibition of this pathway with AC inhibitors, enalapril, lisinopril, have been shown to reduce the cardiac remodeling and improve survival in these patients who have had MI, especially those with left ventricular ejection fraction less than 40% and anterior wall MI. Certain beta blockers, metoprolol, carvedilol, have demonstrated similar benefit in all patients following MI, likely through inhibition of sympathetically driven cardiac remodeling pathway. Aldosterone antagonists, spironolactone, have shown survival benefit in patients with MI and left ventricular ejection fraction less than 40%. Got it? Okay. Okay. So it is the Lee-Rich syndrome. The patient with erectile dysfunction and several risk factors, age more than 50, hypertension, substantial smoking history for peripheral arterial disease, and uh, his thigh and gluteal pain with exertion suggest claudication or restricted blood flow. Therefore, the best next step in evaluation of his erectile dysfunction is ankle brachial index ankle brachial index measurement to evaluate for peripheral arterial disease. So relatively proximal atherosclerotic Relatively proximal atherosclerotic occlusion of the bifurcation of the aorta, the most common iliac artery. Aorto-iliac occlusion restricts the blood flow of the external iliac artery, creating claudication of the hip, thigh, creating claudication of the hip, thigh, and the distal lower extremity. An internal iliac artery with further distal limitation through the superior gluteal artery and internal pudendal artery. Such aorto-iliac occlusion is often referred to as Lee-Rich syndrome, characterized by a triad bilateral hip, thigh, and gluteal claudication, absent or diminished femoral pulse, and erectile dysfunction. Absent or femoral erectile dysfunction. Erectile dysfunction is due to flow restriction from either aorto iliac atherosclerotic occlusion or more distal to the internal iliac or internal pudendal artery occlusion is a warning sign of substantial coronary artery disease, as it commonly precedes the development of coronary artery disease angina by 3 to 5 years. Got it? Is it isn't it like in like uh, pericardial effusion, the X-ray, la, water heart looks like a jar water bottle type. Okay, so it is malignant pericardial effusion because he has a history of malignancy and chemotherapy. Okay, this patient with 2 week history of worsening dyspnea and fatigue and enlarged cardiac shadow with clear lungs on chest X-ray, the most consistent with pericardial effusion and is concerning for malignant effusion gives. Given this patient's history of lung cancer, lung cancer is the most common primary tumor implicated in malignant pericardial effusion. Malignant pericardial effusion, pericardial involvement occurs either by direct tumor extension or malignant spread through the blood or lymphatics. This often results in subacute accumulation of the pericardial fluid accompanied by progressive stretching of the pericardium. Therefore, patient may experience only non-specific symptom dyspnea, fatigue, until enough fluid accumulates, typically 1 to 2 liter, to increase the intrapericardial pressure and compromise cardiac function, cardiac component. Transthoracic echocardiography is used to establish the diagnosis of the pericardial effusion, estimate effusion volume, and access for hemodynamic impairment, right atrial and ventricular collapse. Echocardiography can also guide for pericardiocentesis, which should be performed to acquire for cytologic analysis whenever malignant pleural effusion is suspected. Got it? Is it aortic stenosis? Okay. I do. Okay. We have done the same mistakes. Okay. So severe AS has three criteria: diminished and delayed carotid pulse. Can you hear me? Okay. Diminished and delayed carotid pulse, pulsus parvus and tardus, late peaking, crescendo, decrescendo, systolic murmur, and soft and single S2 during inspiration. Soft and single, soft and single S2 during inspiration. Late peaking, crescendo, decrescendo murmur, pulsus parvus and tardus, diminished and delayed carotid pulse. And the option C is early peaking systolic murmur, suggest mild to moderate AS. Okay, early peaking systolic murmur suggests mild to moderate AS, so it's not wrong totally. The patient with exertional syncope and delayed carotid upstroke. Uh, Exertional syncope and delayed carotid upstroke most likely has severe AS, and a late peaking systolic murmur is expected. Late peaking systolic murmur, late peaking. Okay, in short, like mild to moderate AS, there is early peaking systolic murmur, but in severe AS, there is late peaking crescendo decrescendo murmur, and aortic stenosis has soft and single S2, and there is pulsus, parvus, and tardus. Got it? You want me to? Yes. Okay, I am reading the explanation. Okay. The severe valvular stenosis obstructs the left ventricular flow, reducing pulse pressure and weakening systemic pulsation. The highly thickened and calcified valve leaflet necessitates the generation of higher left ventricular pressure before they open and causing peak blood flow across the valve to occur later in systole. The severity of the stenotic valve leaflets also causes a soft aortic valve closure A2 and delay it to the point that during inspiration it is nearly simultaneous with pulmonary valve closure P2 narrowed splitting. Expiration delays A2 closure even further and paradoxical splitting may be appreciated. Okay, you explain the last part. Why you told me the late? Yes, yes, mild was early. So late due to the last portion, the severely stenotic valve leaflets causing soft aortic valve closure in dealing the. Okay, okay. Next. He has hypertension, isn't it? Is there any diabetes? Is there no? Uh, okay. So only hypertension. So two epic 7. Why you are not doing the chats back when I have told you I was just checking you what are you doing? I told you that he has hypertension. No, when, whenever you find in the stem atrial fibrillation, don't think otherwise. It's whenever you find atrial fibrillation. If it is valvular, you will find the valvular and non-valvular. If any atrial fibrillation, non-valvular atrial fibrillation, don't think anything. In the stem, you need not to read the stem also. Just read it is valvular or non-valvular. If non-valvular, just do the Chatsback. In Chatsback, she is woman. We need only two, isn't it? Her age is 68. In uh in female, sorry, we need three. Sorry. So she has hypertension, and she is a female. So she she has got only 1 point as she is female. She is female. She got 1 point. She is has hypertension and age is 68, in between 65 to 74. So she got 1 point. So it is three. Got it? If you don't do the chats back, then it would be confusing. When you find in the stem AFib, do chats back. Then you, if you don't find the apixaban or this rivaroxaban, apixaban, this sort of thing, they are talking about the warfarin, then give the warfarin. If in the stem there is warfarin, so like if in the option, like in the option, you find the warfarin. When you see the warfarin, think about the valvular one, because only the valvular heart disease we use the warfarin. Apart from the valvular heart disease, we actually don't use warfarin, and we are not using warfarin these days. Apixaban, rivaroxaban, these are the good drugs. Yes. Wait. In this question, this is okay. You think first, and then I will try to. I think that I found a clue. I don't know the answer. I haven't given the answer. Okay. Clue is like he has sinus bradycardia, but he has only first degree AV block. but the features look like the a complete heart block. And if you in complete heart block, or in those heart block, if you give atropine, the bradycardia will gonna improve, but it does not improve. It hasn't improved. So this is the clue. Oh, wait. Okay. Why I am saying it's a clue? Because mm, in a complete heart block, in complete heart block, the treatment would be transvenous pacing or pacer, cardiac pacemaker, isn't it? But in first degree AV block, we do not give pacer. So it is not the complete heart block one. It is either any sort of toxicity, but because she has done, yes, cardiac, a digoxin toxicity will cause AV block, yes. Yes, wouldn't cause bradycardia, so digoxin rules out. It is not the answer. So, yes, it is beta blocker toxicity. It is very hard actually, and we know that beta blocker we need rapid, uh, uh, like rapid glucose. Beta blocker cause hypoglycemia. Okay, we need to read this explanation. You are talking about the hypoglycemia and beta blocker one day. Okay. Okay, this patient's presentation: bradycardia, AV block, hypotension, diffuse wheezing is suggestive of beta blocker doses. Bradycardia, AV block, hypotension, diffuse wheezing suggest, yes. Intoxication with calcium channel blocker. Intoxication with calcium channel blocker, digoxin, and cholinergic agent can cause similar symptom, but wheezing is more specific. For beta blocker toxicity. The cardiac effects of beta blocker are mediated by inhibition of beta 1 receptor activity, resulting in reduced intracellular CAMP, cyclic AMP. Reduced CAMP decreases contractility in the contractile cardiomyocyte and slow conduction in the pacemaker cell, resulting in sinoatrial and atrioventricular node dysfunction. The typical clinical presentation is bradyarrhythmia, sinus bradycardia, cardiac arrest, AV block, and low cardiac output with hypotension, and signs of poor organ and tissue perfusion, cardiogenic shock. Hypotension should be treated with intravenous fluid, and symptomatic bradycardia causing hemodynamic instability should be treated with atropine. In addition, glucagon is useful counteracting beta blocker toxicity. It acts by directly increasing the cyclic AMP via activation of the glucagon receptor, bypassing the blockade. Androgenic acts by directly increasing cyclic AMP via activation of the glucagon receptor, bypassing the blocked adrenergic receptors to increase the heart rate and contractility. Got it? Okay, other treatment include calcium gluconate, high dose insulin with glucose increases contractility, and intravenous lipid emulsion therapy binds lipid soluble medication in the bloodstream. Okay, 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 we will finish today. We Okay, we can do the rest of the question by ourselves, and and